Hello, my name's Dion. I'm the doula. I'm sure you know that already. This video is about babies' positions at the very end of pregnancy / birth. So let's get straight into it. Ever noticed how babies' heads are so much bigger in relation to their bodies than they are when we're adults? It does make them look very cute, and in fact, a lot of cartoon characters have got this attribute as well. You can blame humans' larger than average brain for why this happens, and you would think it would be a lot easier if the head was just in proportion to the rest of the body. But nature has a pretty slick design to counteract this. And that's by making all the bones in your baby's head quite fine or thin in relation to the rest of the bones in the body, and also pliable and flexible. So the skull itself can move or collapsible, not completely. So that's a clever design that is put in there. And you're probably wondering, why are we even speaking about the baby's head? Well, to understand the baby's head or the skull, you're more able to understand the baby's positions, because this is how we kind of roadmap the positions of the baby's head. Also, by understanding this, you understand why your midwife or your doctor might be carrying out certain examinations. Plus, you'll know why your baby has soft spots, and why, as delicate and as precious as your baby is, the soft spot doesn't need to be handled any more carefully than your baby's head would normally. And the final reason is to reassure you that the majority of babies come out with the smallest presenting part, whether that be their head or their bottoms. So that's the reason why we're discussing the baby's head. We won't be discussing bottoms. Well, we will slightly. So here we have our baby model. He or she doesn't have a name yet. We'll come to that. We'll figure one out soon enough. But for the purpose of this video, we're discussing the baby's heads, or the bones in baby's heads. So let's start with the occiput. The occiput bone is right at the back. It's at the base of the baby's head, and it protects the spinal cord. Then we have the parietal bones, which is either side of baby's head. And then we have the frontal bones. In real life, you'd probably be able to feel just a slight crease there, but this model doesn't have one. This crease or suture that goes across is called the coronal suture, like corona or crown. And the one down the middle is called the sagittal suture. And wherever two bones meet, it becomes a suture. And wherever two or more sutures meet, it's a fontanelle. So this diamond shape at the front here is called the anterior fontanelle. And this is what that soft spot feels like. And at the back, we have a triangle shape fontanelle, which is called the posterior fontanelle. So that's the bones of baby's head. So there we have the baby inside the pelvis. And this is in a anterior position because the occiput, which is just there, is facing the anterior of the pelvis, and it's on the right hand side. So this is called a right occiput anterior, or we call it in midwifery, an ROA. That's an optimal position. And it's an optimal position because with uterine contractions, baby goes through, and then as you can see, head is born past the pelvic bone. Now I'm going to just show you another position. Can you see that difference? Baby's occiput now is facing the back. It's still right on the right hand side, but it's facing the back. So it's now right occiput posterior, which is ROP. Now this is not the optimum, but it does occur pretty common. In fact, it's the most common of mouth presentations, about 10% of all labours. So, when baby enters the pelvis in an occiput posterior, they tend to generally not be very well flexed. So as they enter through, it requires more uterine contractions to force baby into this flexed position, which is why sometimes the labour from an occiput posterior position can be a bit longer and sometimes a bit more painful, but not always. And so they are born. There's a few more rotations. And then they have to rotate again for their head to be freed from the symphysis pubis or the pubic bone. First of all, we have the right occiput anterior position. As you can see, baby's well flexed, and most midwives and doctors have the majority of their experience based on this position. And it's exactly the same as the right occiput anterior. They're pretty much the same positions, as you can see here. It's just that the baby's occiput's on the left-hand side. And then we have the transverse lie, and baby's lying across the pelvic brim. And this is not the ideal position for baby, and a lot of second twins are born in or are in the transverse position. There are implications, but we'll discuss this in detail if you have a transverse lie baby. Then we have the oblique lie, similarly to the transverse lie, but on a diagonal. And there are some implications as well for this type of position, and we'll discuss if you like. Then we have the right occiput posterior, which is a less optimal position, but it occurs in 10% of pregnancies, and it just requires extra rotation and uterine or womb contractions. And it's the same as the left occiput posterior, as you can see there. And then we have the breech presentation, which is when the bums come in first, or in midwifery or clinical terms, it's called the sacrum. And this is also called a complete breech as well. Then we have the frank breech, which is when the legs are sticking straight up and baby's still well flexed. And then we have the footling breech, when it's almost like the complete breech, but one of the legs are dangling down. This occurs quite a lot with preterm babies, but we can discuss this at length if we need to on a private one-to-one. And then I found another illustration for the kneeling breech, which is when the baby's knees are coming first in an almost prayer type position. So we've seen the illustrations of all the different types of baby's positions, with the occiput facing front or anterior and the back or posterior. So that's all the different positions for the anterior of the pelvis and the posterior of the pelvis. Why then are posterior positions of babies seen as so problematic? Well, it's best to not think of it in that way, just that it's less common than the occiput facing the anterior. And for the purpose of this video, we won't be speaking really about the transverse or the oblique lie or even the breech. If you have a breech or an oblique lie in your pregnancy, then we can discuss this on a one-to-one and discuss what your options are and what your concerns are. But for the purpose of this video, we're going to go with the most common, which is anterior, which is an optimal position, baby's well flexed, or the posterior. The reason why the posterior or the occiput posterior position is seen as problematic is because of that extra uterine contraction that is needed to get baby well flexed, and for the longer time / perceived or experienced more pain because of it. So the signs that you've got an occipital posterior in labour is a persistent back pain in the sacrum coccyx area. It could be that the labour is not going on longer, but is more protracted, still progressing, but at a slower rate than the occipital anterior. And there's a need or feeling or want to push quite early on before full dilatation. This is the sign. So what can we help if you have an occiput posterior? The greatest thing, especially if it's been noted or diagnosed at the latter end of your pregnancy, so at your 36-week appointment or your 40-week appointment, if you're getting a persistent, that means that your baby's persistently in the same position, that's OP. There's lots of exercises that are known to help with babies spinning around, but not all babies spin round. And when I mean spin round, it means they go from having the back to back to this way. So Spinning Babies is they've got a spinningbabies.org website that you can check out. Also, research has found as well that constant activity throughout the latter stages of pregnancy can encourage baby to go into the optimal occipital anterior position. And also in labour as well is to keep yourself very active. And to cope with any increased or prolonged discomfort, shower heads on the base of your back. So your birth partner can do that. That's known to give quite a lot of relief, especially in the early labour. TENS machine. This is also seen as quite good for pain relief as well. And massages, they're really good, like nice, deep, sort of calming massages on the lower back. And there's a video of this that you can have access to, that's on the platform. Having a calm and confident birth partner as well. So if I'm not there, then having somebody who's had a look at the massage and had a chance to practice them as well. Also, what's really important, we discussed it previously, the uterine muscles or your womb muscles have to contract to aid baby's descent down into the pelvis. And the way muscles contract and work is exactly the same as it works when you're in the gym. And for that to work, you need to have the right amount of sugars, the right amount of salts and fluids and nutrients. That's why it's really important for you to stay hydrated and eat really well when you're in the first stages of labour, to make sure that your uterine muscles have got enough energy to keep contracting. Having a water birth or having a pool, you don't have to give birth in the pool, but being in the pool, being completely immersed in the pool can really provide, from what I've seen, a lot of pain relief. Water births also help with movement in a more gentle way. And it also allows for baby's descent as well. So a pool, whether you want to have your baby in there or not, is really good just to move around and provide space. Baby and mum need to be able to move around as much as possible with an OP presentation. And this is going to sound really patronising, but I don't mean it that way. A lot of women report to me that just before their baby comes, they have an urgent need to want to clean and to make sure that everything is tidy and ready for baby. It makes evolutionary sense, doesn't it? So I would say that really give in to this feeling, as long as it's not toxic substances that you're using, because the actual act of squatting down and getting into those last little areas, this also prepares for your body opening up and gives a chance for your baby to also spin round. But these are all anecdotal, and there are some research behind it, and sometimes that's just the way your baby is. Maybe it just wants to be OP. But what's really important is all of the steps that I've said, is to make sure you've got a calm and confident birth partner. Make sure that you've got your massage techniques. Aromatherapy. Aromatherapy is great, especially if you can drop a couple of drops in the massage oil as well. Clary sage essential oil and lavender essential oil and frankincense, all of those are really, really good. So these are the things that can possibly help. But if there's anything more you want to discuss about the different positions, we can discuss them in our one-to-one privately. I hope this video helps. Thank you.